because you can do this very extensive resection in patients enjoying not only a normal familial, social, but also professional life. If you change the model by telling that localizationism should be burned and that, in fact, it's a networking brain, and we will see more and more the interactions between different networks. And this is the reason why now we should be, to my opinion, especially in neuro-oncology, but also in functional neurosurgery and neuroscientists, in order to better understand brain connectome and to apply this model to the restoration of brain function. Very quickly, when you have a brain tumor, you should be very rigorous in the neuropsychological evaluation of the patient, because they are not so well, and your plasticity is very important, but has some limitation. And the limitation, and this is the point, is not really related directly to the location of the tumor, but to the invasion of the white matter tracts, which are the limitation of neuroplasticity. The second point is that if the tumor is going too much and or too rapidly, you have a risk also to have seizures. And this is another very important point telling you I reached the limitation of plasticity, and you will see why. Very quickly, regarding the oncological issues, this is not today the topic, but if you do not operate low-grade glioma, more or less, the median survival is around 6 to 7 years. If you do extensive resection since the beginning, the median survival is more than 15 years. So everyone knows that it's possible now to change radically the natural history of the disease, so the median survival, but also to preserve the quality of life of the patient by doing intraoperative mapping, but also pre- and post-operative mapping in order to better understand mechanisms of neuroplasticity. And this is finally a kind of functional neurosurgery. Indeed, most of tumors are located within what we call regularly eloquent areas, but in this connectomal model, in fact, Broca's area does not exist. I mean, I did resection in more than 200 patients, and no one kept a permanent aphasia. Why? Because this is a networking brain. And independently of the nature of the lesion, when you have reorganization, this is related to the fact that you have one focal lesion inducing a modification of the whole connectome. And if we start to think about that, it's very important to do preoperative functional imaging in order to better understand mechanisms of reorganization in this patient at that time. Nonetheless, we have understood also that this functional imaging, fMRI, DTI, and so on, are limited, and this is the reason why we decided to do wake mapping for more than 23 years now, by adapting the task into the operating theater, because you will see that more or less you can map and monitor cognitively all functions, adapted to the quality of life of the patient, defined by the patient himself. I mean, of course, they don't want to be hemiplegic, aphasic, but we will incorporate more monitoring in order to give them the opportunity to return to social, professional life, as we said, and by taking into account also the culture of the patient, the environment, because, for instance, if you would like to continue to drive, you can have the license authorization in some countries with an hemianopia, while in 90% of countries it's forbidden. So I don't understand why more and more patients are awakened for epilepsy surgery, most of the time for glioma surgery in the left dominant hemisphere, according to a localizationist view, to map language, but never in the right hemisphere. You can see the functions represented, and we will detail them in the right so-called non-dominant hemisphere. This is exactly what we did yesterday evening. I mean, to discuss all together social cognition, to have non-verbal semantic processing, and so on and so on. You cannot enjoy normal life just with language. And you will tell me, yes, but it's not possible to map and monitor this kind of function into the OR. Of course it is. And it's not only true for us, but now more and more in the literature, it's possible to monitor the executive function throughout the resection, so beyond the oncological issues, just to better understand brain connectome, but also the emotional processing. And this is absolutely crucial, because a human being is first of all emotion. So in other words, we have not just to deal with the cortex, but with the white matter tract, the connectome, in order to avoid to disconnect the vast majority of one hemisphere if you go too far in the depth. This is the reason why we decided 20 years ago to do resection of tumors according to the individual cortical and subcortical white matter tract, and so cortical, but also deep gray nuclei, functional boundaries. So this is functional neurosurgery. We forget the tumor into the operating theater. We remove the lobe invaded by a chronic disease, and we learned a lot about brain plasticity and connectomics. First of all, so we published in Brain the fact that broca's area does not exist and that it's just a hub transitorily connected to the rest of the network if we are speaking about language. We have understood that it was possible to apply the same concept to so many functions, like, for instance, calculation, spatial cognition in the right non-dominant hemisphere. I mean, if you have an hemi neglect, you cannot drive. Working memory, and so on, but also emotional processing by introducing theory of mind into the operating theater. But the cortex, finally, is very plastic. I would say, except some hubs, you can remove more or less what you want, and the patient will recover. Not perfectly, but you will recover. But if you cut the connectivity, suddenly for a few more millimeters, you will disconnect 2/3 of the hemisphere, and the patient will not recover. Exactly what happened to the Le Borgne case. So we have to do white matter tract dissection. It's exactly what we will do with Professor Mondonnet this afternoon in Santander. But we have also to make the correlation between the anatomy, the real anatomy, and not just 5 lobes and that's it, with the cognitive functions. For instance, recently we published in Brain an atlas regarding the negative motor network. It's absolutely crucial for you when you do DBS to understand what you modulate. And finally, if we published this year in Brain, this is because we don't know the functional anatomy, I'm sorry about that, but the control of movement, especially by modulating a network involving not only the cortex, but also the frontostriatal tract and the fat, if we are speaking about not language, but articulation. And this is the reason why also we proposed a new model of connectomal organization of not only movement, but also action. And action is cognition. It's not just I am hemiplegic or not. But to do that, we have to understand the model. And the model means that we need also the somatosensory re-entry, the feedback, but also the awareness of your own body. Otherwise, you cannot have this control. And this is another paper we published this year in Brain by telling now we have to make the link with awareness. This is true also for visual pathways, of course. If you have an hemianopia, you cannot drive in the vast majority of country, but this is not enough. We have to be aware about the spatial cognition to avoid hemi neglect. It's exactly what we published in Science 15 years ago by doing also DTI before and after surgery. Attentional processing. This is absolutely crucial in order to enjoy normal life. Otherwise, you cannot work. Language per se, you have a dorsal pathway, as you know probably, and if we stimulate it during surgery, we will induce a transitory articulatory disorders and or phonological disorders. But also you can have disorders regarding the syntactical processing, which is crucial if you want to enjoy a normal life. But what is exciting is to see now the interactions between different subnetworks. And for instance, si je décide de switcher in another language, then my executive function was controlling the languages because you have different pathways. So it's a kind now of meta-network. Transitorily, I decided to modulate the interactions between different subnetworks. You have to introduce the semantic processing regarding language, of course, exactly what I am doing now by telling you a message using the verbal processing. So the inferior fronto-occipital fascicle, but also the inferior longitudinal fascicle involved in the not only semantic, but lexical access. Except the fact that the posterior part of the inferior longitudinal fascicle is involved much more in visual processing, and if you put everything all together, you have also a connectome involved, subconnectome, if I can say, involved in reading. So you see that by changing the interaction between different subnetworks, you have different subfunctions, and we have to know that when we go to the OR, and you will see that now I will apply this model to functional neurosurgery by explaining you why you can recover following a left temporal lobectomy in epilepsy surgery, because the inferior fronto-occipital fascicle will compensate the inferior longitudinal fascicle in its anterior part and the uncinate fascicle. And this is exactly why the patients can recover with or without tumor, because this is beyond glioma surgery. We have understood also, thanks to Emmanuel, that we have a control thanks to the involvement of the deep gray nuclei, and especially thanks to the projection fibers of the frontostriatal tract we have seen. And finally, now we are modeling more and more language. Okay, we propose already some new model of language, but interactions between language and other subfunctions. And this is the transitory meta-networking brain I spoke about. And to do that, we have to introduce the amodal semantics, not only using language, but also the deep layer of the inferior fronto-occipital fascicle is involved in non-verbal semantics. I have not to speak, you have understood. And this is crucial to enjoy more life. And this is the reason why it's involved in the knowledge of yourself, what we call the metacognition. I mean the fact that I am aware of my brain control, processing, executive function, and, in other words, knowing of knowing. And what is exciting is to know that the right inferior fronto-occipital fascicle, and not only the left, is involved in supramodal processing regarding amodal semantics. And this is logical because we published also recently the fact that you have a bilateral representation of the dorsolateral prefrontal cortex, which is a hub between the dorsal pathway and the ventral semantic pathway. And now we start to build really a meta-network because you can play with that, but it's not enough because we have to play between this executive function, semantic processing, and emotion. And this is an interaction also. And then this is the reason why we decided to introduce the mentalizing task into the OR, because when I was objective by doing postoperative cognitive but also emotional examination following resection of patients I did in the right so-called non-dominant hemisphere, finally they had some kind of deficit regarding especially irritability, schizotypic traits, depression, and so on. So we decided to map and monitor the mentalizing, in other words, the theory of mind, the empathy, into the operating theater, and we observed that there was a distributed cortical network with the inferior frontal gyrus in the right so-called non-dominant hemisphere, prefrontal, so dorsolateral prefrontal cortex, and superior temporal gyrus. So you have a network, and this network is connected by the inferior fronto-occipital fascicle with a bilateral representation, and finally, you can play with this tool. But it's not enough, because you have a higher level of mentalizing, which is to infer the intention of others. And this is absolutely crucial for social cognition. Otherwise, you cannot deal with other people in front of you. Otherwise, you have autism. And this is the reason why we have also to map the right non-dominant hemisphere, including now the connectivity, not only speaking about supramodal semantics, but also for mentalizing. And when you put everything all together for mentalizing, you have 3 levels at least, because this is the new model now we will publish in a few months, and probably in 2 to 3 years, I will add another level of interaction between semantics and mentalizing. And this is the reason why we can also go beyond the introspection, the knowledge of yourself. So this is a new model of the right non-dominant hemisphere. You can imagine, this is non-dominant. We can do that under general anesthesia because we don't care. Because if the patient is not hemiplegic, we're happy. No. But fortunately, the brain will restore itself against us, against neurosurgeons. Brain plasticity is magic, and this is the reason why when you have low-grade glioma, as I said initially, before any symptoms, most of the time you have already a reorganization of the network. That's true for the functional reorganization, but also for the structural modification. We demonstrated, for instance, recently that when you have a tumor within the insula, in the contralateral hemisphere, you have already an increase of the volumetry. So that means that the structure was modified before you do surgery, in addition to the functional reorganization, because based on this modification of the anatomy, the connectivity, then you can, for instance, following a supplementary motor area syndrome, do a postoperative functional imaging demonstrating that you have a compensation thanks to the contralateral hemisphere. And this is absolutely beautiful for neurosurgeons, especially in oncology, because over years you can see this modification of the map in the same patients, and then to come back to remove more tumor, while in the meantime, of course, the patient was still alive and enjoying normal life because you did the first resection according to functional boundaries, and to remove more the second time while preserving the same quality of life. For instance, here, by removing the knob of the hand, or removing, using 2 surgeries spaced by a few years, the so-called Broca's area, which does not exist, definitely, or to remove the Wernicke's area, because you preserve the connectivity in the depth, and you can see now in your mental imagery the arcuate fascicle, the inferior fronto-occipital fascicle, the anterior part of the posterior half of the inferior longitudinal fascicle. If you cut it, then the patient will be disconnected. But if you don't cut, and if you use postoperative cognitive rehabilitation to push this plasticity, you can obtain this kind of very extensive resection, once again, in patients with 5 hours of neurocognitive examination, which are perfect. So the results, how to use it, and in my field is in low-grade glioma, so almost 800 patients with a resection within, once again, Broca's, Wernicke, you see behind the labia vein, the central area, the corpus callosum, the paralimbic system, blah, blah. No mortality, 0.5% of severe permanent deficit related to deep stroke. More than 99% of patients recovered. 30% of improvement. That's crazy. The patient is well because he had just a seizure before surgery. You remove Broca's area and the patient is better following that. Yes, it's possible. 80% of positive impact on epilepsy. More you remove the brain around the tumor, because it's a diffuse glioma, so do resection according to functional boundaries and not try to remove a tumor mass which in essence does not exist in glioma. Then more you will control also epilepsy, so more you will decrease anti-epileptic drugs, more you will improve the quality of life of the patient. This is functional surgery. Just speaking about overall survival, you can see that we have more than 16 years of overall survival now, with more than 25% of patients still alive, with more than 20 years of follow-up. That means that we change radically the natural history of the disease, then this patient should enjoy a perfect normal life based on the knowledge of the connectome. And especially so this meta-networking theory. I will just show a few slides to conclude. Now, the goal is to better understand what we did. So to do not only preoperative functional imaging, but also postoperative functional imaging to see the impact on the reorganization of the connectome due to the surgery itself, and not just due to the glioma. And we demonstrated, because you can do non-invasive serial longitudinal functional imaging, that there was a transitory decrease of the connectivity between both hemispheres following surgery. And that's true when you do epilepsy surgery. And it explains, especially, that you induce a transitory supplementary motor area syndrome related to a decrease of this interhemispheric connectivity, and then you have a re-increase when the patient will recover. But that's true also at the level of the thalamus and cerebellum. So we should see the whole network, just speaking about movement, for instance, because supplementary motor area could be, as you know, of course, mutism, but also akinesia. So I'm speaking about what you do when you put DBS also. You modulate a whole network. Everyone knows that. But now we start to understand this network and what we are doing, because the anatomy was not known, especially the frontostriatal tract, for instance. Now we did the same thing for language, before and after surgery, with fMRI, in this case with specific tasks, but also we'll publish a new paper with resting state. So we started to understand how we modulated the connectivity thanks to surgery itself by removing the tumor and then increasing significantly the median survival. But it's true for higher cognitive function like attentional network before and after surgery, or even for, as I said, metacognition, the knowledge of yourself, knowing of knowing. This is absolutely crucial. And then we put everything all together, the stimulation sites, more than 1,500, to elaborate an atlas of critical functions, both at cortical and subcortical level regarding all functions we have seen. I mean, not only movement, but also control of movement, semantics, verbal, non-verbal, control, executive function, and so on and so on. You have understood. It will be published in Neuroimage, and according to that, we started to understand that we have more or less understood the keyboard, but now we have to play the concerto. And to do that, we have to preserve the minimal common brain, because once again, this is the limitation of neuroplasticity and especially the connectivity. So this is the reason why we published also a paper on brain with, in the MNI template, with the limitation of plasticity index for each voxel. In other words, you can predict after a brain damage if the patient will recover or not with more than 90% of reliability. And this is true also before to go to the operating theater. For instance, in this example, I told you you can remove the anterior temporal lobectomy. You can do an anterior temporal lobectomy and the patient will recover. Yes, that's true, except if the tumor already involved the inferior fronto-occipital fascicle, which will compensate the ILF and the uncinate. So you can have this kind of model before to go to the OR. And to conclude, the interactions between different networks. This is finally the goal now. Emotion, semantic processing, executive function, language, movement. And this is what we are calling now the network of network, because transitorily you will have a combination of different networks. You will decide about that, normally, in order to adapt to the environment. And it will be transitory because, in fact, the brain is just a succession of equilibrium states, but also you can decide, or by working a lot, if it will become permanent. And this is the reason why we can change, modulate our shape of our brain. You remember, of course, when you play piano and so on, many papers demonstrated that there was a modification of the morphometry and the reorganization of the function, but permanently, except if you stop to do piano, for instance. Why it's important? Because the traditional concept when you stimulate, and especially when we are doing mapping in awake patient for glioma surgery, blah, blah, it's just that we are stimulating at this level and that we are stimulating one area corresponding to one function. I know very well neurosurgeon's brain, and I know that 90% of cases, this is exactly what they think. You can forget it. In fact, you can stimulate just one network by inducing transitorily one sub-deficit, for instance, movement control or semantics and so on. Or you can stimulate some hubs, and you will introduce a desynchronization within the meta-network, preventing, for instance, a patient to do two things simultaneously, exactly what we discussed with Santiago Ril-Robles yesterday. He told me sometimes I have asked a patient to move and to name, and finally, he's not able to do both simultaneously at the end of surgery, but if I ask him to stop to move, then he will name again. This is a problem of meta-networking. And of course, it will be the link with the next talk by telling, how do you want to operate the brain if we don't know the functional anatomy of the brain, which is in fact dynamics? How do you want now to restore the brain if we don't know the functional anatomy of this meta-networking? So, in conclusion, Connectomics and plasticity should be incorporated in functional neurosurgery, and I don't see any difference between removing a brain tumor, if you do that according to functional boundaries in order to give your patient 99% of chances to return to normal life, including work, rather than to do a temporal lobectomy in epilepsy surgery or to put DBS by telling this is functional neurosurgery. This is just brain surgery. Thank you so much.